Hello, guys.
Hey.
We're going to talk about the complications of a Picc line, midline, central line, and the way that we address those complications. So let's just assume that we get a call for a Picc line that has a sluggish flow. First thing we're going to do, we're going to assess that catheter visually.
Yeah. So if you go in the room, you got a nurse that said my Picc line's not flushing. Go ahead and go in the room, talk to the patient. First thing to do before you even start manipulating the catheter is just to do a visual inspection. You want to make sure that arm doesn't have unilateral swelling. Take a look at the insertion site. Make sure you don't have any redness or purulent exudate, and also that your dressing is clean, dry, and intact. Those are the first things you want to do before you even start touching the catheter.
The first intervention that should be universal is changing your needleless connector. 80% of the complications with a Picc, midline, or central line are going to happen in this needleless connector, probably due to lack of flushing. So you can change all of these needleless connectors. Make sure when you do that you're using alcohol and cleaning the lure prior to attaching the new needleless connector. And then once you do that, do your brisk pulsating flushes and assess it, see if you have return flow. By changing your needleless connector, you're going to fix 80% of the complications.
Yeah, so if you're in a situation where you go and assess the catheter, you go to flush it, you change your needleless connectors, and you're getting a hard wall of resistance, absolutely no flushing, even with a good amount of pressure, you're probably looking at a mechanical kink. Some ways to troubleshoot that Joe mentioned is retracting your catheter half a centimeter, that may resolve it.
Mm-hmm. So do a dressing change.
Yep, do a dressing change, pull your catheter back half centimeter. And if that doesn't resolve it, then you should consider getting a scan. You should see if there's any kind of mechanical kink.
And mechanical kink is solvable sometimes. Remember that with a Picc line, you can pull it back about 3 centimeters and still be in the lower SVC. Anything much more than 1 or 2, 3 centimeters, you're going to be out of the SVC, and it has to be replaced. Another thing that is worth noting is sometimes you have buildup or residue inside the catheter, and TPA or cath flow product is another solution. And so you'd need to read the instructions and get checked off. Basically, you insert cath flow into the catheter, let it dwell for 30 minutes or so, try to retract that out, and often that will chew up any clot or debris inside the catheter, any biofilm.
So you're going to assess you visually inspect your device, and then you're going to go straight to needleless connectors and doing a power flush. That's going to resolve majority of your issues. And then you kind of have 2 trains of thinking. Do you have some kind of thrombus that's inside of the catheter? Is that, or do you have a fibrin tail, something going on at the tip of the catheter? There's a lot that could be going on. That could be the route, or the other route is you have a mechanical kink. So you have 2 ways of solving different problems.
It's worth noting that all central lines, like a Picc line, a central line, a dialysis catheter, are considered a non-functioning line if they're not drawing back blood. A midline, on the other hand, is considered a functioning line if it's flushing, even if it's not drawing blood. Right. It's due to the location of the tip. If it's not drawing blood, it really needs to be addressed and fixed. It can't be left.
Yep, it is a non-functioning cath in all lumens. With cath flow, if you guys are going to give cath flow, you just need to be careful not to agitate the vial too much. Sometimes if you have a very sluggish Picc line, you can pop the syringe, you can pull back, pop it, and that will exchange some of the fluid that's in the lumen of the catheter. There's also a stopcock method. If you can get a 3-way stopcock, you can pull negative pressure to pull some of the fluid, or you can create negative pressure within the lumen of the catheter, close that stopcock off, and then allow that negative pressure to pull the TPA into the catheter. So there's some tricks around it. And the biggest thing, and this is something that Joe is huge on, is the simplest way to avoid these problems is to educate your patients and the bedside nursing staff to do hard flushes before and after every use. That is going to solve majority of our problems. And then also just good education with dressing changes, not adjusting the position of the Picc line, because that could be causing the mechanical issues.
Try to empower patients and family members to speak up in front of nurses. When you're empowering a patient or a family member in the presence of a nurse, the nurse puts it in the back of their head, the importance of flushing and alcohol-impregnated cap usage. That just makes them do the right thing even when no one's looking.
Yeah, it's 2 simple steps that if everybody's doing, it's great for everybody.
I hope you learned a lot from this.
Yeah.
See you next time.